Hello and welcome to the Becker's ASC virtual event. We are excited to have you join us for today's session, Best Practices for Orthopedics and Multispecialty ASCs, sponsored by Mizuho OSI. I am Laura Dearda with Becker's Healthcare, and I will be your moderator for today's session. Before I introduce today's presenters, I would like to go over just a few housekeeping notes. You can submit any questions you have throughout the presentation by typing them into the Q&A box that you see on your screen. We look forward to hearing your questions. You'll also find a few other engagement tools on your dashboard. Be sure to check out the resources section and fill out the events survey. Finally, this session is being recorded and will be available on demand following today's event. We will send you instructions on how to access the on-demand recordings once today's event concludes. Today we are joined by Corey Hall, CEO of Marin Specialty Surgery Center, Dr. Brian W. Sue, a spine surgeon at Marin Specialty Surgery Center, Dr. Daniel B. Chan, an orthopedic surgeon at Cypress Creek Outpatient Surgical Center. At this time, it is now my pleasure to turn the floor over to our first presenter, Corey Hall, to begin today's presentation.
Well, thank you, Laura. It's my pleasure to be here, and I want to thank both Becker's and Mizuho OSI for the opportunity to speak in this session. So as Laura said, I'm the CEO of Marin Specialty Surgery Center. Just a quick bit about my background. I've been in healthcare now for over 20 years. The first part of my career as a physician assistant in orthopedics, and then several years in the medical device industry, followed by a few years with digital health care strategy and development, and now with Marin. Marin Specialty is a 3 OR, 1 procedure room surgery center, roughly 14,000 square feet in size. We have a predominant focus in orthopedics and pain management, which makes up about 70 to 75% of our volume, along with other specialties such as urology, plastics, vascular, and ophthalmology. The structure of our surgery center is that we are a partnership with a physician group here in the Marin area, 49% owned by Physician LLC and 51% by SCA. In May of this year, after a building process, we relocated from a much smaller surgery center into our new center with overnight stay capability. And due to this, we have also launched our total joint outpatient program and our spine outpatient program. So some of the topics that I was asked to discuss today is really kind of best practices for outpatient joints and spine. What are some tips before adding these service lines? How are some of these decisions made to add these service lines? How did we win over some of our non-ortho shareholders? And then getting staff on board, training, education, and kind of measuring our success. So as I kind of thought through this, I kind of come back to these 6 C's that you should know for your center as you're starting to evaluate the opportunity to open up these 2 critical service lines. And I'm going to hit all of these as we talk through here. So clinical costs, contracts, commitments, communication, and then competition. So one of the first things and one of the major center points of conversation for us as we talked about launching into these programs is obviously the clinical aspect. One of the big things I want to point out is making sure that you know all of your accreditation guidelines by your accrediting bodies. We're AAAHC certified as well as CMS, so our big focus was in adding this was the overnight stay portion of it, particularly Chapter 20. I'm not as familiar with the JCO accreditation process, but with CMS, we also found Appendix L to be quite helpful, just in reviewing to make sure policies and procedures were correctly written. The second thing I think is extremely important when launching into these 2 service lines is you need to ensure that you have a great team around you. Make sure that your director of nursing, PACU manager, OR manager are all fully engaged and involved with not only the procedures and protocols, but also policy creation when launching into these programs. And then you have to have honest conversations with your SPD area, your supply chain, to ensure that they're able to handle the increased demand in these areas with the addition of these service lines. And then if you don't have overnight capacity at this point, you're going to have to look into staffing solutions for overnight if you have the ability to keep patients overnight. A couple of the big things to think about is, do you have a physician champion who's going to be championing these 2 service lines? For us, we're very fortunate. One of the speakers here today, Dr. Brian Sue, was our physician champion for the spine service line. And we had a couple other physicians who do total joints who are physician champions with the launch of that. So those were critical pieces to success. Another one is, do you have an engaged medical director? We do. He's actually very engaged. He is an anesthesiologist by training, and so his input on policy creation and protocolization was key, and he's a very active member in our quality council, med exec, and governing body. We also have an engaged anesthesia director who is fundamental in working with our surgeons in creating our ERAS protocols, which is going to be key to successful patient outcomes. And then last but not least, to think about from the clinical aspect is, how are you going to layer in these cases into your current block schedule? With these particular cases being higher acuity, sometimes longer in length, more demands on your staff, really taking a thoughtful approach to your block schedule on how to manage these cases effectively without sacrificing any type of clinical quality, I think are big questions that you need to think about and answer. The next C I want to talk about is costs. There is a cost to entry into these two product lines, and how are you going to finance these options? A couple of things that were front and center for us is, for the spine line, was the addition of the Trios table, or commonly known as the Jackson table. And for our total joints, it was the HANA table, because multiple surgeons that do joints here do an anterior hip approach. These are investments that need to be well thought out, and can be large investments for your center. But I'll tell you that from a surgeon standpoint, these are absolutes that they will need to be successful to do these cases in your center. The other thing to think about is, what other specialty equipment are you going to need as you launch into these lines? And in particular, higher priced equipment such as high-speed drills, specialty cauterization devices like the Aquamanus or Plasma Blade might be requests from your physician group, and so on. And these can be some higher priced additional equipment items that you really need to think about. Instrument and trays are going to be additional costs you're going to have to incur. There's going to be instrument sets, retractor sets, and multiple other things that physicians are going to want. Most surgeons have a particular retractor that they're very fond of, that they're going to want you to go hunt down and make sure that you have in their sets ready to go. In addition to the instruments is more of an SBD question, but how are you going to process these additional instruments? Are you still wrapping your sets in paper? Are you transitioning to something like a Genesis tray, which does not require a paper wrapping? And can you save some costs there with that transition? As far as additional costs, it's going to be an additional burden on your sterile processing area, not only from a labor standpoint, but is there going to be, in addition to your sterile processing area, additional autoclaves and things like that to be able to support the number of trays that are going to come along with these two service lines? Inevitably, there's going to be some labor cost uptick with additional cases and or the addition of overnight staff that need to be considered, and what those strategies are. And last but certainly not least, there is going to be an additional supplies needed through your supply chain system. Do you have the capacity to store those additional supplies, and have you had a conversation with your supply chain team on how we're going to order those? What I would also highly encourage anyone who's thinking about this is, get your surgeons engaged in every step of this process with these costs, not only so they're aware, but so that you're ordering the correct things, and it doesn't become a huge burden on the supply chain part of it. The next aspect of this is really one that's also very critical, and that's, I think it's a good time to do an evaluation of your contracts, and in particular your CPT'S. And why is this important? Different regions in the country are going to have a different payer mix. I think it's really important that you understand what your particular payer mix is in your region. Are you a heavy Medicare region? Do you have heavy private pay? Do you do a lot of work, or do your physicians do a lot of work comp? I think these are important questions to know as you dig into potential reimbursements for these cases. Another part of this, caveat to that, is, are the appropriate CPTs on your contracts? When was the last time your contracts were negotiated? And are the reimbursements viable to start up a total joint or spine program? And the reason I bring this up is that knowing when the last time your contracts were negotiated, knowing what the emphasis was on that contract negotiation is really important. If you are just starting up a total joint or spine program, these CPT codes may not have been front and center at the last contract negotiation if it was 2, 3, or 4 years ago. And so reimbursements may not have been a central focus for your payer engagement team or whoever negotiated your contract. Knowing what your payers reimburse is critical, and are they going to reimburse for implants? For us, we have Medicare and one private payer who does not reimburse for implants. And so these are critical things to know, particularly when you're negotiating implant pricing. And then also, have you had the ability to negotiate the reimbursement for high-cost supplies into your contracts? And knowing these things can really make a difference on your bottom line on how you generate revenue for these cases. Last but not least, it's always good to know who's in your corner with these negotiations. Are you a standalone ASC, meaning you're out there by yourself and have no other assistance in this process? Are you part of a large managed care organization like NSCA or AmSurg or USPI? Or are you part of a large healthcare network that can really, in both of these last two, can really help with the contract negotiation, help leverage multiple centers across that, and really help with your reimbursement. So all things to consider in terms of your contracting and CPTs. I think the next thing to really consider here is also your commitments and communication. And what I mean by that on the first part of the commitments is who's going to be bringing this volume to your center for the total joints in the spine? Are the physicians that are bringing this volume shareholders who have a vested interest in the success of the center and have a vested interest in bringing volume to your surgery center? Are the group of surgeons that are going to bring this volume, are they new surgeons? Are they building their practice up? Are they non-shareholders who could be potential shareholders in the future? And ensuring that your goals and their goals are in alignment with the amount of volume that you're going to need to effectively launch these two service lines and make them profitable for your center. Or are these surgeons who may never be shareholders? Do they have commitments or non-competes with a large healthcare system that prohibits them from being shareholders? I think all of these things are important factors when you start to think about the committed amount of volume that can be brought into your center to help really finance the launch of these service lines. Having honest conversations with your physicians up front about what these volumes are going to be is key. And the reason that these things are important is ultimately you're going to have to build out a pro forma or prospectus of what this looks like in terms of financing and launching into these programs. And having honest conversations about volume is really going to help you put some numbers together. One of the key points that they wanted to address is how do you win over your non-ortho shareholders in this process? I think the biggest take-home point on this is at the end of the day, they're surgeons, they're investors, and they're business owners in your surgery center. You need to show them what the projections are going to be and build out a realistic pro forma. This tails back to having honest conversations with your key surgeons that are bringing this volume as to what that volume is going to look like and what a ramp up is going to look like. I think if you can effectively show them the numbers and what it will take to finance or pay off some of these large capital investments, I think they're going to get a lot more comfortable with the initial upfront spend to get this type of a service line up and off the ground. One thing in terms of communication that I can't stress enough is include your staff, include your staff, include your staff. I sat down multiple times with our director of nursing, multiple members of our staff to talk through this process, talk through the addition to the service line, what kind of stresses these are going to add to our staff, and what kind of staffing needs we're going to need. Staff training and education is key. We were very fortunate that we had very engaged surgeons who participated very actively in the staff training and education, which was huge for us and the successful launch of the program. And then how are you going to communicate with your vendors? Ensuring that sets and trays are delivered on time and are there for all of your cases. Next is competition. I think it's also very important that you evaluate your general geography for ASCs in the area. How many other ASCs are in your area? What service lines are they covering? Is there a good opportunity for you here, meaning no other ASCs are actually doing outpatient spine or outpatient joints? And if they aren't, this is a great opportunity. But if they are, what's the reputation? Are you going to be able to launch an effective program in this area if it's densely populated with other ASCs that are currently already doing outpatient joints and spine? One thing to consider, how's your affiliation with the local hospital system? Are you going to be a partner with them, or are you a partner with them, or are you going to be a pain for them? And the reason I bring this up is total joints and spine are great revenue generating cases for the hospital. And this can be a pain point potentially if you're seen to be taking volume away from them. So I think it's important that you consider this during your evaluation process. Do these local hospitals depend heavily on joints and spine for their revenue? And I think, again, something you need to be considering. And then how are you going to bring value to your patients? We know that surgery centers are very, very safe places to have surgery. We can have improved outcomes. We decrease the risk of infection. With the advent of great ERAS protocols, patients are recovering very well and going home. And I think we can really have a great improved patient experience for them in the outpatient setting. So in conclusion, before I pass this on, I think total joints and spine are done very safely in the ASC. I think this has been well known for a while. I think with the advent of ERAS protocols, advancing technology, it just keeps getting better and better. Nothing great is accomplished in isolation. You need to have a great team around you that includes your staff, your physicians, your anesthesiologists to really think about how to effectively and thoughtfully launch these programs. COVID-19 has actually caused patients to look for options other than the hospital. The hospitals now are treating a lot of patients that are dealing with COVID symptoms, and I think patients are looking for alternative options. I think the ASC fits that perfectly. Make sure you're comfortable with the initial startup costs. We know that ASCs can provide great value and great outcomes to patients. And so I think the addition of these service lines just adds to that. And these are rapidly evolving areas in the ASC setting, and I think can be great additions to your ASC. So with that, I'm going to turn things over to Dr. Brian Sue, who is a spine surgeon with California Orthopedics and Spine here locally. He is also the chairman of our governing body at the Surgery Center and was a key surgeon champion in the launch of our spine program to continue the presentation.
Okay, thanks so much for having me. As Corey said, I'm Dr. Brian Sue. I'm a spine surgeon in Marin, California in private practice. I happen to also be the medical director of spine surgery at Marin Health Medical Center, and I'm the chair of the governing body of our surgery center. These are my disclosures. The biggest one is I'm a shareholder at the surgery center. So we'll go through some case types if you're a spine surgeon thinking about doing spine surgery at an ASC, preparing the staff, look at our specific ERAS protocols, and I'm going to spend some time focusing on anterior cervical fusions and cervical disc replacements because I think those are the procedures that kind of cause the most angst for surgeons when they're trying to migrate their cases to a surgery center. ASC case types, I have seen all of these case types done at surgery centers. Not all of these are done at our center, but these include anterior cervical fusions, disc replacements, posterior cervical laminoplasties, posterior decompressions. I've heard of surgeons doing anterior lumbar surgery, lateral surgery, MIS fusions, laminectomies, and these really are all the surgeries we would do at a hospital, except for, big deformities or 2, 3, 4 level, multi-level anterior surgeries. I will say that in general, as a surgeon, I'm pretty conservative. We want to be safe. We want to provide high quality care, as good, if not better, than your local hospital. And we want to do it in a very safe setting. So in spine surgery, to me, that means phasing in the different types of cases that you may think about doing. So if you're going to do surgery center cases, my recommendation is to start with something like a microdecompression or a lumbar microdiscectomy. These are cases that are straightforward. They take 45 minutes to an hour. They're typically outpatient anyway at the hospital. And if you're doing these at the hospital, I'm certain these patients go home the same day. Once you've mastered those and the staff is comfortable, then you move towards anterior cervical fusion or cervical disc replacements. After that, cervical foraminotomies. And I put foraminotomy after fusion in anterior surgery, even though it may be a surgery that has less post-op risk, because the positioning for a cervical foraminotomy, either in Gardner-Wells tongs or in a Mayfield, can be somewhat complicated. Then I think cervical laminoplasty and lumbar MIS fusions is phase 4, and then anterior surgery, lateral surgery like lateral fusions, X-lifts, standalone A-lifts. I think those are reasonable to do. I do have friends that do them across the country. I think this really has to do with your comfortability, the need for a blood blank, because if there's catastrophic injury to the vessels and there's no blood blank at the surgery center, that can become an issue. But the point of this slide is to phase in different case types. The biggest thing for me is predictable pathology. As spine surgeons, an ACDF can be done for severe cervical myelopathy, severe cord compression like this patient here who has an ossified fragment, or somebody with a radiculopathy or a soft disc and a normal looking neck. I would not do calcified synovial facet cysts. I wouldn't do something where there's a slightly aberrant vertebral artery. I think really just common sense speaks for itself, but you want to look for predictable pathology. ASA 1 and 2, lower BMI. Most patients are kept in the surgery center and they cannot go home after 23-hour stay or after an entire day because of pain. So if you have a chronic pain patient who is on MS-Contin, OxyContin, that's somebody to be wary of. Big things like access to care at home, patient expectation are probably also the next things after predictable pathology, because if a patient expects to stay 1 day, 2 days, they're going to stay, they're not going to want to go home. Practicing in a hospital setting before an ASC is huge, particularly for cervical fusions. Figure out if your patients are swallowing immediately after surgery, figure out how they look at 23 hours at the hospital. And I would say you should have at least 20 to 25 cases under your belt of any of the case types where you're predictably sending these patients home the same day or within 23 hours before even attempting it in an ASC setting. EROS protocols has largely changed the way that we can manage pain postoperatively. This stands for Enhanced Recovery after surgery. This is protocolization and making sure that we do these things the same way every time. We work with our anesthesia group. There's multiple publications on EROS protocols for spine. Interestingly, these publications are really geared towards inpatient HOPD settings, but we've been using these in an outpatient setting quite successfully. At our surgery center, we use Tylenol, diclofenac, or Celebrex, which is anti-inflammatory, gabapentin, an H2 blocker, as well as TXA. IV TXA is quite expensive. That may be what's used at hospitals. There's really good evidence in the total joint as well as spine literature that 2 grams of TXA preoperatively works just as well, and that can certainly help with bleeding. Intraoperatively, we have a pain protocol that's used. Every patient gets 20 milligrams of ketamine. We use hydromorphone over fentanyl. Patients get Toradol. Obviously, after checking with a surgeon, our cervical fusions don't get Toradol. Everybody gets 2 grams of mag sulfate. Mag sulfate potentiates the effect of the opiates. Patients get Decadron, typically 20 milligrams IV. The cervical fusions get 40 milligrams IV, and I'll talk about that. And we max out local anesthesia. For lumbar discectomy, that could be 70 cc's of 4% marking with epi, and that can work quite well. Exparel, we've largely gone away from. Exparel's expensive. Some payers pay for Exparel on a case-by-case basis, but if you read the literature on Exparel, it's really no better when done in studies combined with Marcaine. Obviously, you have to prepare your staff. We do didactic sessions. This was a whole day kind of boot camp, if you will. So we essentially talk about the indications, surgical procedure, the recovery. We do this with the pre-op nurses, the OR staff, the post-op nurses. Everyone's in the same room when we talk about what the day will look like with a spine patient. We do dry runs, so we will position the patient on the table, tape the patient down, and we actually did this with one of the staff members. We put them on the Jackson table. And then from a surgical tech standpoint, particularly with instrumentation like a cervical disc replacement, we do what's called a skin-to-skin practice run. I did it with all 4 or 5 techs where I'm asking for instruments, asking for the appendiceal retractor, the bovie, and making sure we have every bovie type, the right suctions, etc. This is a whole day deal, but it's kind of invaluable. Make sure you do a dry run for the C-armor, or if you use a Mayo stand cover, do a dry run for that. Actually have your tech in the room. So you practice all these things with a dry run. I want to spend just the last 5 minutes on anterior cervical fusion, cervical disc replacements. Staff education for retropharyngeal hematoma, which is a catastrophic complication, is critical. We train our 23-hour stay nurses to do that. We keep our cervical disc replacement and fusion 23 hours now. You certainly don't have to. There are people who send them home the same day. There's been a few studies, this was piloted by the Cervical Spine Research Society, which I'm part of, where we found that IV Decadron given 40 milligrams times 1 improves post-op dysphagia. For your cervical disc replacements or anterior cervical fusions, post-op dysphagia, the inability to swallow, is going to keep the patient overnight or into the 2nd or 3rd day. Pain is not usually an issue. Pain is an issue for lumbar patients, but swallowing is the issue for cervical patients, and of course, retropharyngeal hematoma. Always make sure you have an ACDF on backup for cervical disc replacements. If you cannot get the cervical disc replacement in, you have to make certain that you can do a fusion. So you have to have the cages, the allograft, the plates always on backup. The reps should bring that. If the surgeon doesn't schedule that, that's a mistake because you don't have a bailout. At the hospital, you can always bail out because they typically have that instrumentation there. Post-operatively, I'm going to talk about the no scare protocol, which is a terrific protocol that's been created by the CSRS. Always have an airway kit in the 23-hour stay room. And the big thing is all of our ORs after my cervical cases, the actual OR is set up for an urgent IND. It's not open, but there's a spine pack there. There's suction set up. There's anesthesia set up, just in case I have to come back to the surgery center to do an IND. There's some neurological complications, Horner syndrome, neurological deficits, epidural hematomas. These are all things that your staff should be aware of. Obviously, for me, the biggest thing is epidural hematoma. This stuff makes the news. How to a push to cut costs and boost profits at a surgery center leads to a trail of deaths. And in particular, they talk about 14 surgery center deaths. Several of them were California. This particular case was in California near us in the Bay Area. This is a nurse, Pauline Tam, just in the surgery center for routine cervical fusion. She developed a hematoma. Staff didn't have the no scare protocol. They tried to intubate her twice. She ended up being transferred to the hospital and she died. So these are things obviously we want to avoid. These cases can be done safely. I would say a mandatory 4-hour or 23-hour stay, discharged with a patient who has the support of an adult overnight, and obviously the surgeon has to be available by phone, anesthesia has to be available. The no scare protocol stands for no strikeouts, cricothyroidotomy after retropharyngeal exposure. This is a protocol developed for safety for outpatient anterior cervical surgery. This was developed with a group of spine surgeons as part of the Cervical Spine Research Society and with the anesthesia societies. So this basically means that there's always a daily checklist. The anesthesia team is on site, nursing team is aware, crash cart is nearby, OR is set up, and everyone understands the no scare protocol. So let me go over, this is in details and words, but let me go over the pictorial, which is a little bit easier. So the no scare protocol is essentially, if a nurse identifies somebody who's having difficulty swallowing, difficulty breathing, anesthesia is called, the surgeon is called, and anesthesia attempts intubation. The mistake in the Pauline Tam case is that they try to intubate multiple times. When there's a retropharyngeal hematoma, the entire trachea is deviated. You can't keep reattempting intubation. You get one strike. So you attempt intubation, you fail, one strike, and you're out, and that's it. After that, patient goes to the OR or at the bedside, the wound is opened, a finger sweep is done. We try to get the hematoma out. After that, we reattempt intubation. You get one chance at that. If you fail, strike two, you go immediately to a cric, and the anesthesiologist or the spine surgeon needs to understand how to do a cric, and the staff, frankly, needs to understand how to do an emergency cric if needed. It'll save the patient's life. So I think if you adhere to the no scare protocol, patients get education on, if you have difficulty swallowing postoperatively, call your surgeon, call their cell phone. I think as a surgeon, it's very important to provide your cell phone to these patients. They have to live near an ED. Make sure on discharge there's a competent adult around. And that adult should be in the same room with that patient overnight. So hopefully that gives you some insight into how to build a spine program at an ASC. I think we are, I would say, halfway through. We are well on our way to finishing doing, a bunch of ACDFs and CDRs and moving on towards MIS fusions and posterior framinotomies. So next, I'd like to introduce Dr. Chan, who I believe is going to talk about total hip replacements. And he's at Cypress Creek Outpatient Surgery Center.
Thanks, Dr. Su. Again, I'm Daniel Chan. I'm an orthopedic surgeon that specializes in trauma as well as hip and knee replacement here in Fort Lauderdale. And so I want to talk to you guys briefly today about why hip replacement surgery is well suited for the ASC and some of the protocols and technologies that we leverage to make this a successful venture, and then a little bit about our experience at Cypress Creek Outpatient Surgical Center. So when we look at hip replacement paradigms, traditionally, even 15 years ago when I was a resident, this was a strictly inpatient procedure. People were in the hospital 1 to 3 days. Pretty much everybody went to inpatient rehab or a SNF, had physical therapy for an additional few months. They were, very slow to recover, and it took months and months for them to kind of get back into the swing of things. And when you contrast that to how we do it now with an outpatient ASC procedure, obviously it's an outpatient procedure. People are in the ASC for no more than 3 hours. Typically for an early start case, we can have patients home by noon. Some hip replacement patients don't even need any physical therapy. They just do their own home exercises. Most only require a couple of weeks of therapy and they're walking on their own. Patients are literally up and walking as soon as their spinal wears off within an hour of surgery, and most can resume activities very quickly. So what are the things that have enabled this transition, such a paradigm shift in such a relatively short time? So I believe personally that the adoption of the anterior approach for hip replacement has been a big factor, including advanced instrumentation such as the HANA table, which I'll talk about as well. Some of the anesthetic considerations, like using spinal anesthetic, which will cut down on your DVT risk, cut down on post-op nausea and vomiting, and enable a quicker recovery. The use of advanced local anesthesia, such as the periarticular injections with or without Exparel, as Dr. Su had mentioned, and as well as the same multimodal pain medication for postoperative pain, like Dr. Su mentioned, with Tylenol, NSAIDs, some narcotics, Neurontin or Lyrica or something along those lines, really make a big difference. But also important is the care coordination between the ASC and your office, as well as patient education and patient selection, really kind of setting up from day one that you are going to have an outpatient procedure. You're not going to need rehab. You're not going to need to stay overnight, and kind of setting up for success from day one. So when we look at traditional hip replacement, it was really done through a posterior approach. People were relying on their sides. You have unreliable pelvic tilt and pelvic positioning. It's difficult to use fluoro. It's harder to judge leg lengths accurately. You have to cut through all those posterior structures in the hip, which can increase the dislocation risk and prolong the patient's recovery. Patients needed to adhere to postoperative restrictions such as no sitting down in a low chair, no crossing your legs, no turning your legs inwards. When you contrast that to the anterior approach, now the patient is positioned supine. You can get constant and reliable pelvic positioning. You can use fluoro. I also use intraoperative navigation as well to really make sure the implants are placed appropriately and to ensure accurate leg lengths. The anterior approach is an intramuscular approach, so no muscles are detached or cut, and that really contributes to the faster recovery of these patients. When we look at obesity, which is a significant problem in this country, you look at that CT scan on the bottom left, there's always going to be far less soft tissue or fat in front of the hip than behind it. So even with obese patients, having an anterior approach hip replacement, even in an outpatient surgical center, is a very viable option. And for me personally, I think the use of a special orthopedic table like the HANA table really facilitates the exposure. There's less muscle trauma, and that can also facilitate an earlier recovery. So the HANA table is, for me, an invaluable tool for the anterior hip replacement procedure. The patient is placed in the traction and leg spars, which allow complete mobility of the leg in space. You can hyperextend and adduct the leg to facilitate femoral broaching. You can fine-tune traction and rotation for people who have deformities, who have been chronically short. You can gradually crank them out to length. And it really kind of functions as a second assistant with an extra set of hands facilitating the exposure. There is a surgery center version of the HANA table that is a smaller footprint that can be stored more easily. And it can also be used by sports medicine colleagues to do hip arthroscopy and other minor hip procedures. For me, I'm a big marketing guy. I spend a lot of time doing online marketing, and so I actually feature the HANA table in my online marketing stuff that I post for Google and Instagram. And patients are becoming very savvy. Orthopedics is a very patient, consumerism-driven specialty. People will shop around for their physicians, and many people call my office asking me specifically, hey, do you use the HANA table, or do you use the special orthopedic table? So having that in your ASC is almost a must-have if you're going to be doing anterior hip surgery. The femoral hook you can see here really facilitates exposure of the femur. So you're not tearing muscle, you're not stretching muscle. You can deliver the femur very easily for broaching and instrumentation. And again, I think that decrease in muscle trauma really facilitates a rapid recovery after hip replacement surgery. You certainly can do anterior hip surgery without the HANA table. Those two pictures you see on the left are a tableless operation, where typically you have to prep both legs in, so it's a lot more work, a lot more fiddle factor. You're attaching these outriggers to a regular bed to try to jerry-rig a femoral hook. And when you drop the leg down to expose the femur, you're actually dropping it below. You're dropping a prepped leg below the sterile field. So I think there's some sterility concerns as well. Whereas if you're using the HANA table, you can see all you need to drape out is a small little rectangle where you're going to make your incision, and all the action happens under the drapes with the nursing assistants to help facilitate positioning of the leg. So with the anterior approach, what are the benefits? Certainly it's my experience that people have much less pain. They have much less time needed on a walker or a cane. In the hospital setting, a lower length of stay, and certainly a less need for physical therapy afterwards. Because we can position the implants more accurately using fluoroscopy and navigation, and we don't have to cut through the posterior capsule, the dislocation risk is lower. There's no particular restrictions on patients. I tell them they can do whatever they want, essentially from day one. And the wound care is easier with an incision on the front of the hip instead of in the buttocks. So, when we're trying to sell patients on, or convincing them on why they should choose outpatient hip surgery, I think there are many, many benefits, and all of these benefits have been compounded with COVID. So I tell patients we have the same technology, we have the same table, the same instruments, the same navigation, same fluoroscopy, even the same staff. So some of the staff in our hospital moonlight at the ASC. So it's basically the exact same team with the exact same surgery that's being done in the hospital, done in the ASC. And like was mentioned before, in this COVID era, there's no inpatients, there's no ER patients, there's no sick patients, and it's a much less lower traffic area than checking into a hospital, sitting in pre-op, sitting in a recovery room with literally 20 to 50 other patients. So all those things, I think, contribute to a lower infection risk having hip surgery in an ASC. One of the things, too, is that we really pride ourselves on the concierge-like service. So when you walk into the ASC, you're going to be greeted by the ASC staff directly. It's going to be a much more concierge-like patient experience as opposed to kind of getting lost in the mix in a major hospital setting. Obviously, this varies depending on your insurance plan and how much of the cost savings actually gets passed on to the patient, but it does cost less to have the procedure done in an ASC. And hopefully insurance companies will eventually pass that on to the patient as well in terms of deductibles and copays and whatnot. One of the things I tell patients is that, if you're not sick, why would you want to be in a hospital? Hospitals are for people who are sick, who are at high risk for getting sick, or for people who need specialized services such as cardiac surgery, trauma surgery. I'm an orthopedic trauma surgeon. So those cases belong in the hospital. But for straightforward outpatient primary joint replacement, the ASC is perfect. I think patient selection, as was mentioned before, is critical. You want to make sure that you tee up your patients for success. So for hip replacement, typically this is someone who's under the age of 65. They have very severe arthritis radiographically that has failed non-surgical care. They don't have any major medical comorbidities. And again, as was mentioned before, we don't want patients on preoperative narcotics. They have well-compensated pain, which means they're going to feel immediately better as soon as they wake up from the surgery. And mostly importantly as well is that they're previously active and independent. Patient education is key. We're going to tell them right away, you're not going to need to stay overnight. You're going to be home by noon. And these are patients who are aggressive and motivated to get better quickly. It definitely takes a village, and especially when you're dealing with ASC surgery where you have less backup and you have, you're not in a big, a big hospital system. You have multiple different touch points. So it's critical that your front office staff, your surgical coordinator is communicating with the ASC staff when it comes to what implants, what trays are going to be required, communicating with the anesthesia staff in terms of what's needed for pre-op testing and coordinating all those things. The recovery room staff, the nurses are basically function as physical therapists because they're going to get the patients up and walking within an hour of surgery. And then also coordinating with your outpatient and home health services to make sure that a physical therapist is going to be meeting the patient at home later that day or the following day to get him up as soon as possible after surgery. So our particular facility is located in Fort Lauderdale. This is located, our surgery center is in an 82,000 square foot medical complex. The ASC itself is about 16,000 square feet. And it was really designed from the ground up to be a one-stop shop for musculoskeletal care. So we have urgent care on site. We have primary care physician offices on site. We have CT scan, MRI. Our practice is building a 10,000 square foot office and physical therapy combined space that's opening next year. So theoretically, from a marketing standpoint, you can really tell a patient, hey, you could come in, see the physician, get your advanced imaging, get pre-op downstairs, get your labs, have your surgery later in the afternoon, and go home the same day. And that's the kind of experience that we're trying to bring to our patients. The center itself was designed from the very beginning to do outpatient total joints as well as spine cases. So we have 5 ORs, 2 are larger ORs. Those ORs are over 500 square foot in size, and they're actually bigger than our cardiac and trauma ORs in our main hospitals. So we were really trying to set ourselves up from success from the ground up and not try to retrofit down the line in the future. One of the questions I was asked to kind of address was, how do, in a very competitive market, how do surgery centers differentiate themselves and attract physicians, either shareholders or participants? So what drew me to this particular surgery center was, number one, the management. And I'm sure Corey does a great job at his surgery center. So we're looking for a similar management philosophy where operations are kind of tightly run, aggressive negotiation for good contracts. We have no problem saying no to payers that aren't favorable, and a management that's actively involved in day-to-day operations. They'll talk to me about potentially lower cost implant or instrumentation alternatives, and just help me to optimize the workflow. The facility, again, this is a brand new ASC. It's only been open for about 2 years. And again, it was designed from the ground up to anticipate and accommodate these advanced cases. It's hard to see in the map down below, but certainly location is important as well, like in anything else, like in real estate. So we're located between 2 major interstates. We're literally right next to a major private airport. So we have easy access to Miami, easy access to West Palm Beach. And so that was important too, in being in an area that was accessible to patients. The other surgeons in the ASC are also kind of similar, like-minded individuals. We all are rowing in the same boat. We're all kind of incentivized to do well. And so I think having quote unquote partners, even though you're not in the same group, you kind of are linked together in the ASC. And so having like-minded individuals is important when considering to join an ASC. And then obviously the most important thing is, how is the ASC doing? I'm happy to say that even though we're a new ASC and we have still, significant startup debt that we're paying off, and we're still running at about 25% capacity, we're still very profitable and distributing dividends quarterly. These are some pictures of the ASC, just showing that we're trying to create a very patient-friendly environment with modern touches. The ORs are very large, so this is me and our HANA table set up in the OR. You can see there's plenty of room for C-arm, plenty of room for all the instrument trays. We can do some of the spine procedures as well that Dr. Su was talking about in the same ASC. So what's the patient experience like? So again, preoperative education is critical. We offer all our patients the opportunity to tour the facility so they can feel more comfortable with it, especially if they're having some hesitation about having an ASC procedure. We set up home health and home physical therapy ahead of time. We fill all their prescriptions for pain medications before they come to the ASC, so they have it in their hand as they're walking out the door. So typically for our first case, the patient will come to the ASC at about 6 a.m. They have a one-to-one nurse, and we're wheels in at 6:30. We have a spinal anesthetic. A total hip typically takes about 45 minutes or even less, skin to skin. And then, so by 8 o'clock, they're in the recovery room. As soon as the spinal wears off, they're walking around at 9:30, and they're usually home by 10. And that afternoon, we have home health get them up and start walking right away. And that's been, really successful for us in terms of getting patients home, and they have a significant rapid recovery head start. So we were the first ASC in the Miami-Dade and Broward area to perform anterior hip replacements. We've done the most total hips in an ASC in South Florida in the Miami-Dade and Broward County area. And I'm knocking really hard on wood because, in a year and a half since we've been doing this, so far we haven't had any complications, as you can see there. And the patients have given us universal positive feedback. And again, I'm big on online presence. We solicit people to leave feedback on Google, Facebook, Health Grades, Vitals. These are some of the examples of people that have posted about their experience at the ASC, and this has in turn generated more patients calling us asking about outpatient total hips. So this one patient said, Dr. Chan said he was doing my surgery as an outpatient. I went in Friday morning, was home that afternoon, and walking unassisted by Monday. Another patient said I had hip surgery at 7 a.m., was home by 1 p.m. I never had appreciable pain. And so building upon these positive experiences that patients have been giving to us, we have this patient who literally flew to Fort Lauderdale from Panama City Beach, 900 miles away, because she saw our stuff online. And I can tell you that 90% of our elective business comes from online referrals. And so this patient says, I can't believe I was walking within an hour. I flew down from Northwest Florida. So I think when you have a well-run surgery center with the appropriate physician champion and the right protocol, you can really start to expand beyond your local area with effective online marketing campaigns, and you can draw from well beyond your primary service area. So that's kind of a little bit about how we've been successful doing total joints. And this is just some of the information about myself and our surgery center if you want more information. And I thank you for your time.
Well, great. Thank you so much. This has been, that is all the time we have for today. I want to thank Corey, Dr. Sue, and Dr. Chan for your time, thoughtfulness, and insights, and Mizuho OSI for sponsoring today's session. And to our attendees who joined us, thank you for making time to be part of our Becker's ASC virtual event. Make sure you check out the other sessions we have going on during this event. And please let us know if you have any questions, comments, or feedback. Thank you again for joining us. We look forward to seeing you at future Becker's events.